here. So I'm going to introduce our very last speakers of the day, Jay Freeman and Jamie Solomon, who did an amazing job of organizing the pre-meeting this year. Many of you may be aware that for many years, NIDDK has sponsored a Research Gaps workshop that occurs on the day before Pancreas Fest, and it's always a tradition to have the co-chairs of that meeting summarize the proceedings of the meeting. And this year, it started off as an NIDDK sponsored meeting and got, I think Jamie said, about 85% of the way through the planning, and then federal funding priorities changed, and poor Jay and Jamie had to pick up the rest, and just did an amazing job putting it all together. So I will turn it over to you, and once you conclude, we'll just go right out to the exhibits and the posters.
Thanks, Melina. Yes, when we lost the support and event planning from the NIH, Jay and I went out and asked our friends and colleagues for help so that we could continue this tradition. And so I just want to make sure that we take the time to thank those groups who stepped up. So that includes CAPER, Nationwide Children's, National Pancreas Foundation, and University of Pittsburgh. So thank you very much. As a basic scientist, I may have taken away a different perspective from yesterday's workshop than some of the clinicians who work with patients a lot more. But at the happy hour last night, Dave Whitcomb made some comments about one of the smartest things you can do is to recognize your limitations. And I think it was a concept that was repeated throughout today, that the more we learn, as Chris said during his mentoring talk, the more we realize we don't know, the more questions that we have. And I think yesterday or today, Steve put up this ivory tower that he was talking about. And what we want is a strong foundation from the basic biology all the way up to a multimodal, validated, like toolbox of therapies, interventions, coping mechanisms, support systems, etc. But what I think was reinforced in this workshop is that what we really have is a Jenga tower that might fall over, because we have a lot of holes in our basic understanding of biology, all the way up to more validated trials like we heard during the patient testimonial this morning. And so we have patients suffering more than they need to be. And so we have a lot more work to do. And just like this morning, yesterday, we started our workshop with patient interview. Dr. Anna Phillips and her patient, Dr. Carolyn Yost, was kind enough to go through an interview and share her experience with us with adult onset recurrent acute pancreatitis. And I think that one of the things that came away for me was it's a network of people that are being affected, not just that patient. It's the patient's family, the patient's friends, the patient's coworkers, etc. And that what they found most helpful is when physicians are able to take the extra time to really listen and give attention, that groups like Mission Cure are having patient support. But I think what also was reemphasized this morning is that there's a variability in standard of care. And it's important to understand that we need to work towards more standardized standard of care, but also that every patient is different and they're going to respond to different things. And that we need to understand biology. For example, triggers of flares was something that the patient yesterday really emphasized. And again, this idea of increasing our toolkit to include all different types of tools to help patients. Our first session was on endocrine insufficiency, and I've listed here the 4 speakers and the titles of their talks. I think for me, as someone who's not an endocrinologist, you know, we've mostly heard of type 1 and type 2 diabetes, but there's in fact many different kinds. And what Dr. Bellin really focused on was that although we think of type 1, type 2, and type 3 diabetes as 3 different entities, they really are probably overlapping. And she came up with 5 conclusion points that were important for how to move forward in understanding type 3 diabetes, and whether it's really unique or not in terms of subtypes and mechanisms, and understanding that. And one area that she suggested we focus on was pancreatic polypeptide, which might be a mechanistic driver of diabetes and driving hepatic insulin resistance. And so that's an area that we need to focus on. And also studying hypoglycemia risk and how the response to hypoglycemia, I apologize, and further studying the therapies that are regulating hypoglycemia, and whether things that we've developed for glycemic regulation for type 1 and type 2 diabetes can be applicable for type 3 diabetes, or if we need something different. There is a lot of debate with about genetic testing and genetic risks, and we'll talk a little bit about more of that in the second half. But Dr. Gudarzi got up and talked about how we're using GWAS studies, genome-wide association studies, to develop risk models, and looking at risk in particular of diabetes as a complication of chronic pancreatitis. And we know that if you develop diabetes when you have chronic pancreatitis, that it increases your morbidity and mortality. And if we can predict who's going to develop that diabetes before they do, we can intervene earlier. And he talked about developing genetic risk scores using common gene variants. And although it's a good start, the area under the curve is only 0.745. And we need to continue to do more studies and look at involving multiple factors into these models to improve it. And one potential way that we did slightly improve it so far, his group has shown that if you look at the addition of genetic risk scores for type 2 diabetes, that you actually improve the risk for the type 3 diabetes. So there's more modeling and more studies, obviously, that we need to do here too, but it's another potential tool in our toolbox for identifying these patients before they get this illness. Autoimmunity is also important in terms of endocrine insufficiency, and talk by Dr. Wasserfeld for University of Florida talked about how autoimmunity actually is, the same features of immunity, except for that the antigens that are triggering your adaptive immune response are, self antigens. And there have been, 7 or 8 autoantigens that have already been discovered in diabetes, but we still don't know what actually initiates that response. And in order to begin to understand that, we need to do more longitudinal sampling as opposed to one-time sampling, which was something that came up in some of today's talks as well. In support of Dr. Gudarzi's work, genetic risk scores could be applicable here for identifying patients that may develop autoimmune responses as well. And then something important in terms of trying to understand the mechanism is he suggests that we need to start collecting tissues, which is not always the first thing we think of in these conditions, and use histopathology. And also, like he found with the type 2 diabetes data informing the type 3 diabetes risk score in the context of type 3 dependent diabetes after chronic pancreatitis. This also type of information, taking it from other types of pancreatitis and type 1 diabetes, could inform developing risk as models for autoimmunity as well. And then finally, those are some of the issues that we have in terms of understanding mechanism, but how do we manage and monitor for complications of type 3C diabetes? And this was a great talk by Dr. Phil Hart, who talked about distinguishing between the different types of diabetes, and whether how we can use taking advantage of patients that have these diabetic and endocrine insufficiencies as an opportunity for early detection for other complications such as pancreatic cancer. And identifying patients, again, the focus is for a lot of these talks was how can we identify patients before these complications even develop? And the mechanistic knowledge gaps that he pointed out that are really important to follow up on are the mechanisms related to treatment induced hypoglycemia, vascular complications, both micro and macrovascular, the role of adjuvant therapies, and also all of this screening. How can we do that in a cost-effective way that will help us identify these patients, but not put too much of a burden on the healthcare system and on the patients. And just in general, recurring theme was we need more robust evidence-based data. And one thing that also came up both from the patient perspective and from our clinical colleagues was the establishment of a patient-centric care team that's multidisciplinary. And that came up again today, that the patients that do the best are the ones who have access to a host of different specialists. The second session was focusing on the exocrine insufficiency. And one thing that these are just some examples of different types of pancreatitis, cystic fibrosis, et cetera, that we need to, in order to treat exocrine insufficiency, we need to screen for it and identify it in patients. And Dr. Chris Forsmark gave a disheartening talk almost about how far behind we are on achieving this, that there's no consensus definition of what exocrine insufficiency is. There's no consensus on determining severity. The symptoms and clinical features are very nonspecific, and unfortunately, we have no widely available and accurate diagnostic test. So he introduced several tests that are available that we use, the most prominent one being the fecal elastase test, but as we all know, it doesn't have the greatest sensitivity and specificity. And doesn't address the fact that, as we heard both yesterday and today, that there's nutritional deficiencies, both macronutrient levels and micronutrient levels, that we will also need to be measuring and addressing. And so really, the biggest need is to come up with a standard definition and develop a test. So towards developing tests, Dr. Tumulus Herkis, radiologist at Indiana University, shared with us some data in which we can use MRI as a potential non-invasive way to look at exocrine function. And I am not a physicist or a radiologist. So I can show you that the T1 signal, he went through what that is and what's bright and not bright on a T1 scan, but the idea being that you can develop a signal based on the proteinaceous material in the pancreas, and that quantity score does correlate with the available pancreatic exocrine function data, and in this way would be a non-invasive way, and potentially could be made to be cost effective, although I know sometimes MRIs can be expensive. And this could be another quantitative way that might be more reliable than some of the other tests that are available. As I mentioned, one of the things that we're not always measuring or not paying enough attention to is the macro micronutrients. And so Dr. Kristen Roberts gave a talk about how nutrition affects many different AP and CP outcomes, as you can see in her graphic, everything from abdominal pain to diabetes to bone disease, sarcopenia, dysbiosis, and talked a lot about how just measuring fat maldigestion or absorption is not sufficient. And we really need to be measuring the fat soluble vitamins. And the problem again with that is we have inconsistent techniques that are reported in the literature, and they're largely inadequate. And so we need to do a better job of measuring these and getting detailed data in our nutrient studies so that we can understand the connections between all the aspects of disease and the nutrient levels. So finally, Dr. Sarah Jane Schwarzenberg gave a talk on how can we overcome these challenges related to EPI, and focusing on the goal of getting patients to normal digestion and the repeated challenges of costs, no simple method for choosing the dosage, no good endpoint to measure. So in the context of EPI, the biggest gap is really we need to define what it is and how we're going to measure it. And how we're going to decide if our treatment, if our enzyme replacement therapy is being effective. And in many cases, it was suggested that the focus has just been on weight, or if the patient's symptomatic, on amelioration of those symptoms. But we really need to look at more endpoints than that. And finally, there was some discussion about the enzyme replacement therapy is derived from porcine, pigs, and this table, hopefully you can read it, shows that the composition is actually quite different between humans and pig pancreatic juice. And so maybe we can develop something more effective and potentially less dependent on animals, as companies are now starting to come up with synthetic recombinant pancreatic enzymes. And I will turn it over to Jay to talk about the second half of the day.
Thank you, Jamie. So the next section we had was on other metabolic abnormalities. You can see the speakers there. Chris told me not to read them to you. So Darwin gave a really nice talk on osteopathy, talking about the pathophysiology and treatment. He started off with a pretty simple looking at PROCEED data and just simply showing that the rates or the prevalence of osteopathy and chronic pancreatitis were quite high. I mean, you're seeing women in their 50s to 70s with 75% osteopenia. So clearly a problem. More complicated is why. So he's not here, and I'm assured that the endocrinologists in the room don't care about bone, so I can say whatever I want. But generally what the point here was is you have a balance between osteoblasts and osteoclasts, and inflammation disrupts that balance, in which instead of, let's be really simple, having one osteoblast and one osteoclast, you have an upregulation of your osteoclast so that you have two into one osteoblast. So basically the chronic inflammation disrupts the hormonal signal so that you have an increased bone breakdown that over years results in this osteopathy. So it's great to recognize it, even if we don't understand, like how do we really, diagnose this? And one of the themes that we had over the next two talks was really opportunistic imaging. And he made this really nice, or showed this really nice figure where you can save like hundreds of millions of dollars a year in healthcare costs by using the imaging that you're probably already going to be getting. So in this case, a CT on a patient with chronic pancreatitis. And so if I'm sure Andrew can tell me that it takes probably about 10 seconds to draw this circle on the L1 vertebrae and get a measurement where we can start getting a screening for osteopathy. And that was what he was recommending for these patients as an easy screening mechanism. He then did talk about treatment a little bit, some of the basic things, but in red, this was his color, not mine. He really pointed out the idea that we probably aren't treating our patients with pancreatic insufficiency well, that by having our pancreatic enzymes there, we'll absorb our nutrients, our vitamins, and we actually can make an impact probably on this, both as a treatment, but also as a preventative strategy. From there, Dr. Ronald Summers from the NIH gave an amazing talk, and I am not going to do it justice. He presented virtually, and he did not share his slides. He had these amazing figures of how they're using AI to really segment the pancreas and get amazing images. But one of the things that I am able to share from his talk is, again, talking about this idea of opportunistic screening when you get imaging. And what they're really looking at doing is how do they use machine learning to, again, segment the pancreas. So this is an image of a patient that is normal, one with pre-diabetes and one with diabetes, and basically looking at the structure of the pancreas and how they're starting to learn how to get better characterization of this despite the underlying pathophysiology that's present, and more importantly, how they're using this technology to get rid of that background fat signal so that they can get a more accurate assessment of the pancreas. Nobody tell me how wrong I am. No, but basically, what he was showing was using type 2 diabetes as an outcome measure, and what they can do with this is if you look at a patient who is non-diabetic, a patient that was diagnosed over 2,500 days before, a more recent diagnosis. Those that go on to develop diabetes in the relatively near future versus those, I'm sorry, so I have this backwards. So they'll get diagnosed later, and then these are the had it diagnosed for the longest period of time. And you start to see the Hansfield units. But even with like way before they develop diabetes, you already start to see this change in the Hansfield units. So by using machine learning and really getting rid of that background noise, they can do this. Now, the second table or the bars down here are then accounting for that mass. You don't see as much of a difference, but you can still get to this idea that they're starting to teach us machines. And in this case, these are all non-contrast CTs. And they're now adapting this technology to contrast CT and MRI so that they can start giving us a better idea of clinical outcomes based on the imaging that we're already getting. So fascinating stuff. He has amazing figures and diagrams. So if you get to see one of his talks or if it's filmed and you can go back and watch it, I highly recommend it. Next, Guru, who's sitting in the front, so you have to be nice to me. Don't say anything bad. Gave us the talk on sarcopenia. One of the first things that I really took away from the talk was this idea that we try to break these conditions up. But sarcopenia really doesn't exist in its own entity very often. So it was part of this triple threat of frailty, malnutrition, and sarcopenia that all have to be considered together. And not surprising, there's multiple pathways within our patients with chronic pancreatitis that get us to sarcopenia. We've talked a little bit about EPI, maldigestion, decreased intake, maybe from gastroparesis or something along those lines. We have these endocrine and these inflammation. I'm so sorry. She almost got you in the eye with the laser. I'm not a good friend. But these are all things that we have to keep in mind as we move forward. And the other thing he was talking about was this really has a significant impact on outcomes. So if we looked at all hospitalizations, those that had sarcopenia for all reasons had a much higher rate of either 1 or 2 hospitalizations per year. When they weren't all pancreatic. If you actually look, it's a lot of non-pancreatic hospitalizations that ended up getting us there. So this really has a profound impact on their morbidity. One of his take-home messages was we just need to have a mechanism to be screening for this. He talked about this screening tool here, but then talked a lot about our muscle strength, our grip strength, things of that nature, and then when to use imaging and our physical performance. And then there was a lot of how do we treat? There's a lot of stuff on exercise, diet, but multiple modalities that we need to be considering, not just one. Then we had Brandon Coe from Mass General, who also gave a great talk, again virtually, and I didn't have his slides. But one of the reasons we asked him to talk was based off this study where they looked at 650 patients with gastroneuromuscular disorders versus 650 matched controls and started looking at their histories of acute or chronic pancreatitis. So a very large study despite being single center. And what they were able to show was there was a higher proportion of patients that had a history of acute pancreatitis or recurrent pancreatitis amongst those that were ultimately diagnosed with GND. Somewhat surprisingly to me, it was not statistically significant amongst the chronic pancreatitis group. But if we looked at controls versus those that had GND alone, versus those that have acute pancreatitis, there was a higher rate of mortality amongst those with GND and pancreatitis, although not pancreatitis alone. And if you looked at hospitalizations, it was really the combination of the two. So really this idea of, whatever the motility disruption may be, seems to be having a significant impact on their morbidity as well. He had an amazing slide that I really wish I had to show with you that really talked about how the chronic inflammation from chronic pancreatitis probably affects the vagus nerve, and at 5 different spots within the upper GI tract could all lead to impaired motility, starting from the esophagus all the way into the duodenum. And so it was a really nice pictorial, and I don't know if it's one that he put together himself. I looked, I couldn't find it. But if it was one of those pictures that I put together, I'd use it in every talk I gave. It was that good. So again, if you have the chance to go back, it's worth looking at that for that one slide. If nothing else, it really is a nice pathophysiology slide and or summary in one slide. And again, this the Victorial the abstract showing that really those patients that have a history of acute pancreatitis are more likely over the next 4 years with an odds ratio of 2.27 to have this functional dyspepsia or some type of GGN, which has a significant impact as far as hospitalizations and mortality. All right, then our next to last session was on nutrition, pain, and genetics. Dr. Steve Pandol gave this really nice talk where he started with a case report of this 78-year-old man who had had chronic pancreatitis and sort of how they got to this decision making of how to give tube feeds. So he really talked about this experience and used this figure on your left as his roadmap. And he showed a number of, PROs, but really after 14 years, the idea was the patient told him that his pancreas has changed. And you could see when he was alternating between oral feeds and tube feeds that all of his PROs were much higher on the tube feeds. And I think one of the things that was really interesting was they were measuring his success and functionality as to how high he could climb up the mountain or the rock, right? So this was a very physically active individual who with jejunal feeding was doing really well. They then started talking about formulas and where we're feeding and what does that do to the pancreas. So when we look, we have placebo on the left, IV, oral, duodenal feeds or elemental feeds, and what the amount of amylase output was, which obviously with elemental was the lowest. This was actually trypsin activity. And again, whether you're fasting or getting IV nutrition, it was very low, went up with polymeric feeds, went down with elemental, and then if we went to distal jejunal, it went all the way down. So this was evidence to support this idea of a distal polymeric feed. And then further hammering this point home, when we looked at those formulas that were higher in MCT versus long chain triglycerides, you see that the lipase within the medium chain never really changed, but it goes up with amongst those after feeds that got long chain formula. Same thing for amylase within both groups. So again, given an idea of where to feed and what type of formula we should be using. Then Dr. Mayafaji from Johns Hopkins gave us a really nice talk on how to use or what the data was on transcutaneous devices. I think one of the things that was really interesting was this idea that neuropathy, not duct pressure, was really one of the drivers of pain within pancreatitis. So this may explain why our ERCPs and our surgical procedures may not work as much. In addition to showing that there was hypertrophy and density, you actually saw this on the histology with this black area being neurologic damage and bundling of these nerves. So that was what kind of this idea of why we should have this transcutaneous devices. One of the ones that have been of real interest was the spinal cord stimulation. Unfortunately, the data on that wasn't great. This was average daily pain and maximal daily pain, whether you were on sham versus on the stimulation, and you can see that those lines are basically the same. I don't think I need to walk anybody through that. One of the other ones that has gotten a little bit of attention is this transcranial magnetic stimulation. Unfortunately, it's not FDA approved, but when you look down here at the bottom, this is the patients had sham versus those that were on active stimulation, and you do see a reduction in pain, although it's certainly not to zero. So there is at least some data for that out to at least 8 weeks. There was way too much here for me to go through, but again, I think one of my take homes from this is great to go back and look at yourselves. She went through all these different mechanisms on how these different transcutaneous devices work. And most importantly, I really liked this slide that really talked about the different modalities, the findings, what the pancreas specific evidence was, and what the limitations are. So this is a great slide to go back and look at if you can find it, and I would highly recommend. Finally, Dr. Liuch talked about CFT modulators and how they could affect the course of RAP or CP. She gave this really nice summary of how pancreatic function affects what our phenotype is, and we can see that even on our sweat tests. We've seen this figure a couple times today already, I know, from Vikesh Singh and the group at Hopkins, showing that amongst those with pancreatic sufficient pancreatic sufficient CF, when they were started on modulator therapy, basically over a 4-year follow-up period, there was no episodes of pancreatitis. She then showed some inspired data that is not yet published, but sort of the same idea. These were 28 patients, only 10 of those that didn't have CF, the rest did. But if you look, there was about 80 episodes of pancreatitis in the 5 years before starting modulator therapy and only 11 afterwards. So giving us some evidence that this could be beneficial in CF or even just our CFTR heterozygotes or homozygotes that don't necessarily have cystic fibrosis. Also touched on the idea that in animal models, we are actually seeing an improvement of the pancreas with these drugs than a non-CF mouse. So this is a cerulean-induced model of pancreatitis in a mouse. This is not a CFTR knockout. This is a wild-type mouse. And you can see the damage that if we give them a combination of what's tezacaftor and ivacaftor, or what was known as Symdeko, or still known, you see that there's far less damage of this. So maybe some evidence that you don't even need to have CFTR mutations to benefit from these drugs. Then we ended the day with a debate, and despite my best efforts of stirring the pot, as Steve would say, these two got along well. But Dr. Maisam Abu Halaja and Dr. Hughes had a debate on whether all patients with pancreatitis should undergo genetic testing or not. My son really talked about the pros being, we can't give definitive care. We can't give everything if we don't have all the data. And by having all the data and knowing what the genetic risk factors are is going to help us to have predictive models to be able to understand what these mean moving forward, so that we can get to interactions and affect interventions, understand the genetic and environmental interactions, which will ultimately lead to precision medicine and reduced healthcare. It was a great talk. I've really narrowed it down to the key points, but really this idea of more data, the more we can do with it, the better off we're going to be. Steve kind of countered with his Gattaca argument, which I loved, by the way. But basically saying that the routine genetic testing is just not ready yet. We're not there for prime time. A lot of times we don't have the phenotypical expression of what these genes mean. There may be social or emotional stigmata that are affected by them that we don't really know what it means. We don't have a great idea of what the penetrance is. We aren't really changing our management much, maybe a little bit in our monitoring, but not necessarily our management based on these findings. There's a lot of third and fourth tier programs are doing a lot of genetic testing, smaller programs, smaller hospitals that aren't. If they do the genetic testing, are we going to have access to it? Or, just kind of not really streamlined at this point. And really data without a highly phenotyped clinical context isn't going to be beneficial. So I think what we really left the argument with was that we all believe that genetic testing has a role in the treatment of patients with pancreatitis. It might even be a little bit different based on whether you're treating a child versus an adult, but there's still not a consensus on exactly what to use, when, and how. So in summary, I wanted to leave this slide blank for a little bit, just to take a moment, even though he's not here. We didn't see him yesterday. Jamie already alluded to this a little bit, but Dr. Dana Anderson was amazing. I hope he's good. I wish we had his presence here, but really wanted to thank him and the entire committee for making this happen. It ended up being a lot of work, but it was a lot of good work, and I really enjoyed getting to do it with you. So thank you. This will not surprise those of you that know me well. I'm going to give you the least scientific summary that you will ever see, but we had a fun day. We learned a lot, and no one was harmed. Going back to something that was said earlier for the trainees, this is a great day to come to learn the gaps. Please go back and look at the slides and the videos if you're able to, because at the end of every talk is where the gaps are. And whatever fits your fancy, whatever you're interested in, this is really where you can find the information as to where to start. At least that's my opinion. So
And
thank
we'll
you.
be publishing a manuscript also describing it, just for those of you who weren't there and don't have access to the slides. And it will come out in Pancreas. We invite you all to go to the reception in the ballroom and next door and look at the posters and abstracts that people worked really hard on